In this lecture, we'll be going over thyroid hormone, its functions, and associated pathologies. So first, we'll go over the synthesis of thyroid hormone. The thyroid hormone synthesis starts from the hypothalamus, where the periventricular cells produce thyroid-releasing hormone and secrete it into the hypophyseal portal system in the pituitary stalk. From there, it goes to the anterior pituitary to cause the secretion of TSH. The way that happens is TRH binds to a G protein linked receptor, causing a conformational change. That causes the activation of the alpha GQ protein, and that happens due to the fact that GDP gets converted into GTP, and that causes the activation of phospholipase C. Phospholipase C goes on to cleave PIP2, which gives you diacylglycerol and inositol triphosphate. The diacylglycerol goes on to activate protein kinase C, and inositol triphosphate causes increased intracellular calcium, which is used for exocytosis of the protein. Once TSH is produced by the anterior pituitary, it goes to the thyroid gland and causes the stimulation of thyroid hormone production, T4 and T3, using the GS second messenger system. So this is the same concept where TSH will come in and bind to the G-linked protein, causing, in this case, activation of alpha GS. And the way that happens is GDP is phosphorylated into GTP, and then alpha GS goes on to activate the adenylyl cyclase. This enzyme converts ATP into cAMP, which then goes on to cause activation of protein kinase C, which goes on to phosphorylate and activate other proteins. The thyroid gland is made up of little thyroid follicles seen over here. The thyrocytes go in a circle and form a little lumen inside, which is filled with colloid. So once the TSH comes and binds to the receptor, activating the thyrocyte to make more proteins, the three proteins that it makes is the thyroglobulin, which is a polypeptide seen here, and it has these tyrosine molecules attached to it, and NIS, which is a symporter, which takes in 2 sodium ions and 1 iodine ion, and pendrin, which secretes the iodine ion from the cytosol into the lumen. Once you have the thyroglobulin and the iodine in the lumen, thyroperoxidase causes reactions. One reaction is organification, where it converts the iodine ion into iodide, and then it attaches the iodide onto the tyrosine molecules. If it attaches 2 iodide ions onto a tyrosine molecule, that's known as diiodotyrosine. And if it attaches 1, that's known as monoiodotyrosine. Once you have this molecule, it undergoes a coupling reaction where 2 of the similar molecules come together, and you'll have MIT or DIT, and they come together. So MIT and DIT will form T3, and DIT and DIT will form T4. And once you have this, it is endocytosed into the cytosol, and from there cleaved in different parts by lysosomes. So you get free T4 and T3, which are then secreted, and MIT and DITs are recycled for their iodine. So what are the functions of the thyroid hormone? In one sentence, it's to increase the metabolic activity of your body. It also has an effect on your heart. It increases your contractility, heart rate, and cardiac output. And the way it does that is by increasing the expression of beta-1 receptors. Beta-1 receptors are G protein linked receptors. They activate protein kinase A, which phosphorylates L-type calcium channels and the phospholambin. When activated, they cause increased contractility, and if you remember your equation, increased contractility results in increased stroke volume, and cardiac output equals stroke volume times heart rate. Increased stroke volume is going to cause increased cardiac output, and increased heart rate, which can also occur due to thyroid hormone by increased gap junctions, which cause decreased time for action potential propagation, can increase your cardiac output. The basal metabolic rate is increased by increased expression and increased activity of the sodium potassium ATPase pumps. Thyroid hormone also increases your blood sugar by glycogenolysis and gluconeogenesis, and it can also cause lipolysis. So what happens when you have too little thyroid hormone? Since thyroid hormone is involved in metabolic activity, too little will cause decreased metabolism. Decreased metabolism just means that you're going to be using less energy, so most of the energy gets stored. And the energy is stored in glucose and then fat tissues and then fatty acids and so on, and will cause weight gain and fatigue. Hyponatremia can also occur in hypothyroidism, and that's due to the fact that it has an effect on the heart, and decreased contractility, stroke volume, and cardiac output will cause low blood pressures. Low blood pressures will cause decreased perfusion of the kidneys, which will result in increased angiotensin-aldosterone system. Increased angiotensin causes stimulation of antidiuretic hormone from the posterior pituitary, which causes increased water reabsorption from your distal nephron, and that will result in more of a volume increase than the osmolar increase, results in dilutional effect on the serum, causing hyponatremia. Amenorrhea is due to the fact that TRH also stimulates lactotrophs in the anterior pituitary to stimulate production of prolactin. And when you have low thyroid hormone, that causes less of a feedback to TRH, and upregulation of TRH causes more prolactin production, which inhibits your luteinizing hormone, your follicle stimulating hormone, and your gonadotropin releasing hormone. You can also have decreased GI motility, and that's because of, in a low thyroid state, you'll have deposition of glycosaminoglycans in the GI tract, and that will cause decreased GI motility and constipation and decreased appetite. Edema is due to the fact that, remember that thyroid hormone upregulates the expression and activity of your sodium potassium ATPase. When you have decreased activity of sodium potassium pump, you'll still have the sodium channels that exist in the cell. And remember, there's more sodium outside and there's more potassium inside cells. So when you have decreased activity of sodium potassium pump, you're not going to be pumping in potassium and excreting sodium to keep the electrochemical gradient. So sodium will travel from high concentration to low concentration, and potassium, there's also potassium channels, but less so. When sodium travels into the cell, it also the water molecules follow. That causes swelling up of cells, and it can cause myoedema. That will show up when you do a reflex on a person, and then they have this muscle pop up, and that's due to the edematous muscle. Patients can also have carpal tunnel syndrome, and this is similar pathophysiology to what we see in the GI tract, where you have glycosaminoglycans and adipose tissue deposition near the nerves, and that causes impingement, and that causes pain. Patients can also have bradycardia, and we already spoke about the pathophysiology due to its effect on the heart. Beta 1 receptors will probably be downregulated in a hypothyroid stage, causing bradycardia, and that can cause dyspnea on exertion. There are several causes of hypothyroidism, and some include Hashimoto's, postpartum, congenital, subacute granulomatous thyroiditis, and renal thyroiditis. So Hashimoto's is the most common cause of hypothyroidism, and it's caused by an autoimmune disease. It's antibodies against your enzyme thyroid peroxidase and the microsomes and the thyroglobulin. Remember that the thyroglobulin is exocytosed and endocytosed in microsomes, and there's microsomal lysosomes also. So if you have antibodies to all of those, that will cause release of the enzymes into the thyrocytes itself, causing degradation of cytosolic material. And degradation of thyroglobulin and thyroid peroxidase will cause the halt in production of the thyroid hormone. So initial inflammation will cause hyperthyroidism, and that's because the thyroid gland stores around 2 to 3 months of thyroid hormone. Even in a hypothyroid state, people will not manifest symptoms until like 2 or 3 months from when they started being hypothyroid, because they have 2 or 3 months of storage. And destruction after you run out of that storage will lead to hypothyroidism. And this is associated with HLA-DR3 and DR5. And patients with Hashimoto's will have increased risk of Hodgkin's lymphoma, and that's going to be the B cell type. And treatment is like any hypothyroid stage, is going to be with levothyroxine. Hypothyroidism in pregnancy is a little complicated. Beta HCG starts being produced by the blastocyst by day 6. That's when it gets implanted and becomes a blastocyst. And then it's secreted by syncytial trophoblasts that make up the outer layer of the chorionic villi. And the beta HCG levels peak around weeks 8 to 10, and it also stimulates the production of thyroid hormone because one of the subunits is very similar to the thyroid hormone, and it can bind to the thyroid stimulating hormone receptor. So this is because in the pregnancy they require increased thyroid levels, and that's because thyroid hormone also causes increased synthesis of your estrogens and like other stuff that's needed in the pregnant stage. Normally, pregnancy is euthyroid, but if a patient is hypothyroid from the beginning and now becomes pregnant, they require 30% more of the medication they were like receiving before. So if they were receiving, a certain amount of levothyroxine, as soon as you find out that they're pregnant, you're going to increase that dose by 30%. And also in your pregnant stage, the upregulation of the estrogen, which occurs, after like a month of pregnancy, causes increased production of thyroid binding globulin, which binds to the thyroid hormone and increases your total T3 and T4, but the free levels of these hormones remains normal. And that is why we need to increase levothyroxine during the pregnancy stage. Congenital hypothyroidism can occur in mothers who have autoimmune disease to the thyroid, like Hashimoto's, and now they become pregnant, and the autoantibodies can go through the placenta because they're IgGs and cause hypothyroid in the fetus, and the fetus will present as pot-bellied, pale, puffy faced with protruding umbilicus and tongue. And because thyroid hormone is involved in the maturation of brain and bone, they'll have, retarded growth of brain and bone. Subacute granulomatous thyroiditis, or Descurvan, is basically a post-viral syndrome. Patients get a viral infection, and that causes inflammation of the thyroid, which causes initially release of the thyroid hormone. So they can be hyperthyroid in the initial stages, and then they become hypothyroid. And because of the inflammation, will generally have tender thyroid, and that's pathognomonic for Descurvans. The disease is self-limited. They tend to recover their function. And the reason it's called granulomatous thyroiditis is because on histology, you'll have granuloma formations. Renal thyroiditis is a fibrotic thyroid which will be immovable, hard like a rock, and it can invade local structures to cause dysphagia if it invades the esophagus, or a deep voice if it invades the trachea and the voice box, and it has to be differentiated from anaplastic carcinoma, which is a similar presentation but seen more in the elderly population. And amiodarone can also cause hypothyroidism. It can also cause hyperthyroidism. And the way it causes hypothyroidism is it inhibits the dihydrogenase in the peripheral tissue, which decreases the production of or conversion of T4 to T3. And no treatment is generally needed because they're clinically euthyroid. It can also, because amiodarone has two iodide molecules in its formula, it can cause high levels of iodine in the body and in the thyroid, which can cause, through Wolff-Chaikoff effect, decreased production of your hormones. And basically, Wolff-Chaikoff effect says that if you have increased iodide levels, that causes decreased expression of thyroglobulin, of the NIS, and of the pendrin proteins. Because you have so much of one thing, it's going to downregulate all the other proteins to try to control what's happening. And this is treated with levothyroxine because patients will generally be hypothyroid. And it can cause hyperthyroidism due to increased production or to destruction. Type 1 is going to be increased production, and type 2 is going to be destruction. Both types of hyperthyroidism will present with increased T3 and T4 and decreased TSH. The way you differentiate both of them is by radioactive iodine uptake test. So in type 1, you'll have decreased uptake, and in type 2, it's going to be undetectable. And the ultrasound in type 1 is going to show increased vascularity on ultrasound, and in type 2, it's going to be decreased vascularity. And type 1 hyperthyroidism due to amiodarone will have to be treated with methimazole most commonly. We don't really use propyl or uracil unless it's in a first trimester of pregnancy because methimazole is teratogenic. Type 2 is treated with glucocorticoids. Lithium can also cause hypothyroidism, and that's because it accumulates in the thyroid gland and inhibits the uptake of iodine into the thyrocytes, and that can cause decreased production of thyroid hormone. But usually these patients are euthyroid, but even if they develop hypothyroidism, they don't need to stop taking lithium. They can simply start taking thyroid hormone replacement with levothyroxine, and that should be okay. Okay, guys, that's it for this lecture. We'll be going over hyperthyroidism in another lecture. So, thank you for listening, and if you liked my lecture, please subscribe and like the video. Thank you.